The respiratory system in association with the cardiovascular system is a crucial support for getting oxygen into the bloodstream and getting carbon dioxide out. There is also a temperature regulatory function that the respiratory system plays as well, though it's not as pronounced in the humans as it is in the animals. So the airways and the lungs comprise the respiratory system. The airway starts from the nose, then the nasopharynx. The larynx is the entrance to the lower airways, and this is protected by the vocal cords and the epiglottis. This protection is very important because the pathway is shared by the esophagus. The food pipe is right behind the larynx, and the oropharynx is common to both the airway and the swallowing pathway. So this protection will prevent aspiration, and the vocal cords of course help us to produce the voice that we have. Epiglottis along with the ariepiglottic folds closes when we swallow and prevents aspiration. And you might remember that sometimes we choke when we are not focused on swallowing. So if you are eating and laughing or talking, you may end up choking because your focus is not fully on the breathing, so this closure may not happen properly and you swallow at the same time as you're breathing. Below the larynx we have the main airway called the trachea. The trachea divides into the bronchi, the right and left main bronchi, and then the bronchial tree. The lungs, there are right and left lungs, and the lobes of the lungs, the right lung has 3 lobes and the left lung has 2 lobes. As the bronchi keep dividing, the last components after 10 to 12 divisions is the bronchioles. The respiratory bronchioles lead to alveoli. So we have the terminal bronchioles, which are the last component of the bronchioles, which don't take part in respiration. Then the respiratory bronchiole has a thinner wall, and then it leads to the alveoli or the air sacs. The blood vessels, which break up into the capillaries like anywhere else in the body, come in contact with the alveolar lining where the gas exchange happens, and this is called the alveolar capillary interface. So here you can see the alveolar capillary interface. So the blood vessels are coming, the lining of the blood vessels. So obviously the capillaries are very fine vessels, they don't have any muscle lining, and it's just the endothelial lining. And you have the alveoli, again the alveolar epithelial lining is there, which comes right next to it. Sometimes in lung disease you may have barriers here, you may have membrane formation, you may have thickening of this barrier, so the gas exchange does not happen as well. You may have components lining the alveoli like the exudate in pneumonia, which also blocks the gas exchange, and that's why in lung disease where the lung is stiff, you need pressure to open the alveoli and help with the gas exchange. So we have the upper airway, the trachea with the C-shaped cartilage which supports it. This is the larynx or the voice box. And we have the lungs, and you have the bronchi, the main bronchi dividing subdivisions of the bronchi, as I told you, 10 to 12 divisions, and then they reach the bronchioles. And this is the lower system, the bronchioles, the respiratory bronchioles, and the alveolar sacs. So the alveolar sacs are like grapes, a bunch of grapes, and this is how the structure looks in the alveoli. So the nasal cavity has some projections into the bone of the face called the sinus, which kind of gives you the tone of your voice, and also there is a cushioning effect, it gives shape to the skull. And we have the mouth, as I told you, the swallowing pathway and the breathing pathway are common in this segment, and then the airway starts, and you have the protective mechanisms at the junction of the larynx, and then the trachea, lungs, and the heart is placed in between in the chest. The ribs have a protective function. They also help to move the diaphragm, which is the main muscle of breathing. So as the diaphragm moves and the ribs lift, the lungs close, and this causes exhalation. When the patient actively breathes, the ribs go down, the diaphragm goes down, and the lung expands, drawing the blood into the lungs, drawing the air into the lungs. So this is the pleural space. So between the rib cage and the lungs there is a pleural space, and actually during a deep inspiration there is a negative pressure created in the pleural space, and this is responsible for the air being drawn in. So the rib cage and the diaphragm support the respiratory effort. They are the main muscles of respiration. The rib cage has a main stabilizing effect as well, so the lung doesn't collapse in. The respiratory control centers are in the brainstem, which is mainly the pons and the medulla. They control the respiratory rhythm. There are situations where feedback regulation happens, and sometimes a basic rhythm takes over if there is an injury to the main upper part of the brain, the cortex. The feedback system is based on oxygen and carbon dioxide levels, and also the pH levels in the blood and in the cerebrospinal fluid. So different levels of receptors are there. The surfactant is a chemical produced in the alveoli. This helps to stabilize the alveolar wall and prevent its collapse. So when there is exhalation, the alveolus becomes small, and if the wall is not stabilized with the surfactant, the alveolus may collapse, and then to open it again needs a lot of effort. So the alveolus is maintained in a state of half open state by the surfactant. In premature babies, the surfactant tends to be low, and so we may have to replace the surfactant or use a pressure to stabilize the alveoli so it doesn't collapse. In older people and children as well with infections, there is a condition called acute respiratory distress syndrome, where the surfactant may go down and the lung behaves like it does in a premature baby with lung disease. The main function of the lung is to receive oxygen into the blood and wash out carbon dioxide from the blood into the alveoli, and this is called gas exchange. Obviously, you have to breathe at a regular rate and rhythm, and sometimes when we exercise, we breathe deeper because the requirement of gas is more. So the gas exchange happens at a faster pace. So it's not just the lung that needs to work more, the heart also pumps fast. That's why you have the fast heartbeat. You feel the heartbeat increasing as you work. And normally we have 6 to 7 times the resting capacity, reserve capacity. So if you are exercising, you can increase your circulation to that extent before you actually start tiring out. But in certain diseases, this reserve capacity drops significantly, and when you are recovering from a disease as well, your reserve tends to be low till you reach your peak level again. So to measure the lung function, we have the oxygen saturation, the blood gas analysis, which will show us pH, PCO2, which is the partial pressure of carbon dioxide, and the partial pressure of oxygen in the blood. We also have the measurement of lung volumes. Like if you have asthma where the lung flow is reduced, you can blow into a peak flow meter. You take a deep breath and blow actively, and this velocity of peak flow is fractional excretion within the first few seconds. So that can be measured, and it reflects whether the airway is narrow. So in asthmatics, for example, you blow into it, your FEV1 is reduced, and then you take the inhaler and test again, it will improve, which is like a confirmatory test that you have airway narrowing or reactive airways. You can have lung disease occurring from congenital defects in the airways or lungs. You can have infections of the lung tissue called pneumonia, and we have airway narrowing as in asthma. You can also have foreign body aspiration when we choke on certain materials. You can have aspiration pneumonia when you are having a fits. For example, your sensorium is not normal, you vomit during a fit, you may aspirate and that material blocks the lungs, and that becomes an aspiration pneumonia. Smoking affects the lungs in multiple ways. It causes airway irritation. The airway lining proliferates in an abnormal way in smokers, and there is a higher risk of cancer formation. They also have a higher risk of bronchitis as they don't clear the secretions as well. The airway is lined by cilia, which helps to move the material back out of the airway. So this clearing mechanism is important. We have a lining called mucus, and when you are in a dry environment, you get the mucus becoming thicker that may clog the airway. You have a condition called cystic fibrosis where the secretions are very thick and they may also block the airway. So when the lung doesn't function as it should, we end up with respiratory failure in the extreme situations. The type 1 respiratory failure is primarily a failure of oxygenation and gas exchange due to lung disease. So here the lung is not normal. It's a stiff lung usually like in pneumonia. Type 2 respiratory failure is a failure of gas exchange related to lack of effort or air movement. So here it is about gas exchange in the alveolar interstitial level, while here the lung doesn't get the air movement because you have brain injury, the child is comatose or the adult is comatose, or there is neuromuscular weakness as in paralysis, and you can also have asthma, which leads to a type 2 kind of respiratory failure because the air doesn't move into the airway because of the narrowing. and this affects carbon dioxide exchange. But of course, with the severe type 2 failure, you will have reduced oxygen as well. So the assessment would include blood gas, and the X-ray is a big guide for lung disease. Nature of the problem can be figured. The airway can be seen on the X-ray as well. When we put a tube into the airway to support breathing, you can visualize that on the X-ray as well. And then you have to do additional tests depending on what you think. So testing for infection, so you can culture the sputum, you can have infection on the tests like markers of infection in the blood, and CT or MRI chest could help in certain cases as well. The treatment of the lung disease would depend on the severity of the condition. So mostly it's supportive management and then specific management. Supportive management may be just oxygen given through the nose, or it may be ventilatory support. And ventilatory support is basically aiming to stabilize the airway and to hold the alveoli open, giving a certain pressure. So you may give it through the nose when it is called non-invasive, and it's continuous positive airway pressure or CPAP. You can have invasive after we insert endotracheal tube into the airway, where the breathing is taken over by the mechanical ventilator. There are certain conditions like in obese adults, the upper airway may collapse. We get snoring and obstructive sleep apnea because the airway becomes almost closed during a certain phase of sleep due to the reduced tone of the muscles in the airway, and this leads to a kind of type 2 respiratory failure, and this happens in a repeated basis. So the person may not sleep well at night, they feel drowsy during the day, they may not function effectively. In children, a similar picture is produced by enlargement of the tonsils at the entrance of the airway, as well as adenoid, which is right behind the nose. So the child will be mouth breathing, snoring will be there, and you may have obstructive sleep apnea when your snoring becomes deeper in pitch and suddenly the patient stops breathing for a period, then they wake up with a sudden jerk. So this is how the monitor looks in the NICU or the ICU. You have the heart rate monitor, you have the blood pressure, and you have other parameters like the gas levels which are measured. Temperature of the patient may be measured. This is non-invasive support by a mask. You can also apply a prong into the nose to deliver that. A blood gas is usually done from arterial samples. Usually you can insert an arterial line or put a needle into the artery. This is not the typical site, this is just to illustrate. So this is what you would see, the pH, the PCO2, partial pressure of oxygen, and here that's the oxygen content, which is calculated from the hemoglobin and the partial pressure of oxygen. You also get the bicarbonate and the base excess. And this is a patient on mechanical ventilation. You have an endotracheal tube in the airway and the tubing connects to the ventilator. You're seeing the gas flow in a repeated basis. And this is the infusion pumps. The IV treatment in a sick patient happens through infusion pumps to support them. Next, we will be looking at the gastrointestinal tract. Do review the previous videos in this sequence, and I hope they are useful. Thank you.